Welcome to the About Sex podcast. I'm your host, Angela Skirtu, and you can find me at www.therapistinstlouis.com, and you can find this podcast at www.aboutsexpodcast.com. Today, we are talking with Dr. Becky Lynn, who is a gynecologist and women's health specialist. She specializes in sexual function and is trained as a trained sexual counselor. She's known for her research looking at the effects of cannabis on the sexual experience in women, which I'm very interested in finding out more about, by the way.
Okay.
She's also a local expert in persistent genital arousal disorder and has helped many women bring happiness to their bedroom. So, Dr. Becky, thank you for joining me today.
Thank you for having me.
All right, now before we get into this next conversation, I just want to stop to give us a word from our new sponsors. So I am now working with a really cool company called Let's Get Checked. You can find them at trilgc.com/staykinky. What's really cool about this company actually is that they're doing testosterone testing for men and hormone checks for men and women. A lot of people are struggling with hormonal imbalances and reduced testosterone levels, which really can impact your sex life. And so more and more men and women are trying to test their hormone levels to see how they're doing. 1 in 4 men over 30 are actually low in testosterone. Symptoms you might want to look at include fatigue, erectile dysfunction, low sex drive, anxiety, brain fog, even having a hard time making decisions, which is basically most of my client population. Just teasing. But I mean, enough of you who come see me are actually really struggling with testosterone levels and your sex drive. So what's cool about this group is you can pick from either a male hormone test kit, a female hormone test kit, or an STD test kit. And what's really cool is they send it right to you in your home. You do what you need to do to take the test. And depending on what test you use, you'll either have to do a blood sample or a blood sample and a urine sample. And then you send it back and everything's completely confidential. And basically, they deliver to your home, they collect your sample, they review your results for you. So depending on what happens with your test, they may provide a prescription in some cases. Usually it would only be for something like if they're treating STDs. If you do end up having something longer term like hormone therapy, then you'll likely be referred to a longer term provider. But at least you'll know where you stand. So it's really cool. Your results are available and they'll be reviewed by a physician. And then a nurse will contact you for a consultation over the phone. The Let's Get Checked laboratories are CLIA approved and everything is completely anonymous. So again, that website is trilgc.com/staykinky and use the coupon code STAYKINKY to get 20% off. Well, so I'm just going to jump right in. Tell me all about cannabis and sex.
Sure. My research in that sort of fell into my lap. I didn't set out when I went to medical school to be the sex doctor and the cannabis doctor, but I noticed that in my practice, a lot of women who would come to me with sexual problems would sort of mention on the side that, using marijuana seemed to help them. And so that made me curious to see what does the data show? Is there research into this? And as you can imagine, there really wasn't a lot of, research in, medical journals and the medical literature on using cannabis and sex because it's been illegal.
Yeah.
But on the internet, everywhere, it tells you that cannabis is the best aphrodisiac ever and, all sorts of things you can find on the internet. So that led me to do a study, which was a questionnaire. I mean, we obviously cannot give women marijuana for fun, say go have sex and tell me what happens.
You have to have people who are already doing it and are willing to tell you.
Exactly. So that's how we got around that limitation.
Uh-huh.
And so we did a questionnaire of anybody who walked into our gynecology practice. This was when I was at St. Louis University. And we asked them, what happens when you use marijuana before sex? How did it affect the sexual experience, orgasm, lubrication, desire, and pain? And we found that the majority of women reported an improvement in the overall sexual satisfaction, desire, orgasm, and a decrease in pain. And it was about 50-50 with lubrication. Even though marijuana is technically a vasodilator, you would think it would increase. But there's a lot of issues, with a questionnaire study.
Since my clients or my listeners don't always know what vasodilating is, could you explain that real quick? Yeah.
Absolutely. It just means that the blood vessels dilate. And so that's what helps a woman lubricate. When you become aroused, you get more blood flow into the vagina, the blood vessels dilate, and actually lubrication is sort of kind of the transfer of fluid from inside the blood vessels to the vaginal mucosa. So you want vasodilation, and it also helps with engorgement because those blood vessels dilate, they get bigger, and you feel engorged and aroused.
Okay, so it's a good thing. You want it to be
It's a
engorged
good
and
thing.
aroused.
Yes, yes. The other thing that we found in the study is that people who used marijuana more frequently um, were more likely to report better orgasms in general than women who used less frequently. And people who did use marijuana before sex were more likely to have better orgasms in general than people who did not. So it was actually interesting. And when you look at the literature, and there have been a couple of other questionnaires that I've seen published, it goes along with what other questionnaires and other studies have shown. The only thing is this is all in moderation, because if you smoke too much or use too much, however you use it, and you can't move, that's not going to help you.
Yeah.
So
You need to use your body to have good
yes,
sex.
exactly. So we're talking moderation here. So yeah,
Well, yeah, because if you use so much of it, you might just veg out on the couch and eat too much. I mean, there's that other
exactly.
option that can occur.
Yeah. So if you are planning on doing this, you have to kind of know yourself, and sort of test the waters before you go all out, I guess.
I think that's what's hard about, like, so I know, it's obvious because it's scheduled at I think it's Schedule 1, like a narcotic. It's very highly
Mm-hmm.
scheduled in terms of its illegal qualities. And as a part of that, it is very much difficult for us to research it in any sort of quantitative
Mm-hmm.
way. So yeah, what we get are like stories and case studies and people doing kind of these like research like you're describing, where it's kind of, all right, well, if you're already doing it, I'll just see what you're doing. But then it's hard to find out like what is the best amount for people to take. When is
Right.
it too much or too little? Because there's also not enough testing done to be able to decide what would be the best controlled dose, for example, because you just kind of
Right.
smoke some and hope for the best.
Exactly. Yeah, no, that's a very good point. So that the studies are definitely lacking. And I hope that in the future, over the
Mhm.
next 10, 15 years, that the body of research will grow.
Me too.
Maybe the United States isn't there yet, but Canada, it's legal, recreational, and for medical use, all over Canada.
Hmm.
So that opens a lot of doors for some better quality research.
Are you seeing positive things then in some of the research coming from Canada?
Actually, I haven't seen much coming from Canada. The last two studies that I saw looking at sexuality and cannabis, I saw one from Stanford, was also a questionnaire. And then there was another questionnaire, and I can't remember what institution, but it was in the United States.
Okay. Well, and
Yeah.
so you don't just, I mean, like this is something you study, but I mean, in general, you also help women with libido issues, painful sex, PGAD.
Yes.
I'm wondering which of those you want to talk about first.
We can talk about libido first.
All
That's
right.
fine.
Well, what kinds of reasons are women coming to you for help for when it comes to libido?
Yeah. So I would say libido is one of the most complex issues, low libido, to take care of because so many things play a role in libido.
Hmm.
Everything from chronic medical conditions to what your parents taught you about sex,
Hmm.
to how you feel about your body, and to certain medicines or depression, anxiety. There's so many things. So
Absolutely.
when I see women for low libido, I do a very extensive and thorough history because the last thing I want to do is be like, oh, you have low libido? Here, take this pill. That is
Hmm.
not the right answer. And I find that when women have low libido, it's generally not due to just one thing. There's a lot of contributing factors. And so that's why I like to do a very thorough history and focus on all the contributing factors. And if somebody needs a medicine, then that's a possibility. They certainly don't have to. But I want to make sure that they get the comprehensive evaluation and focus on the things that can be adjusted.
Absolutely. Honestly, I mean, that's part of my work too. I'm a sex therapist too. And
Yeah,
I mean, the reality is you can give somebody a pill, but that doesn't change if they hate their husband. you know,
exactly.
you still have to think
Exactly.
at things like, look at things like relationships and if people are
Hmm.
getting along or if, yeah, to your point, like one of the things that shows up in my office a lot is people's just comfort with sex and whether they're a
Yes.
sexual person.
Yep.
If you struggle to identify yourself as sexual, then it's really hard to like give yourself permission to feel desire. There
Yeah,
can be
that's a
so
good
many
point.
hangups.
I like how you phrase that as like your identity as a sexual person. That's true. And I think we get a lot of that from what we were taught about sex as children and growing up. But yeah, I like that.
Well, it's been a running theme in my practice is like how people identify and relate to sexuality. In fact, one of my
Hmm.
favorite stories was actually when I was working with an accountant and he said, "I'm not sexual like that. I'm an accountant." And I imagined him. No, I know it drove me nuts because I was like, "Wait, but are you like do you have your tax calculator in the bedroom and like as you're going you kind of like do math?" And he was like it totally threw
That
him
might
off
work
guard.
for some people.
I know. But like there's just to your point, there is just way more to this than a pill. So like
Right,
when you
right.
do that whole workup, then what are some of the things that you help people do from there?
Hmm. So I do. There's a lot. So like I will always look at their medicines. A lot of women are on SSRIs, which are things like Prozac, Zoloft, Paxil, and they have no idea that it can be affecting their libido and ability to orgasm.
Mm-hmm.
If they're depressed, I might talk to them about seeing a therapist or a psychiatrist, or exercise is really great for mood issues.
Absolutely.
I see a lot of women with cancer, specifically breast cancer, who have terrible pain with intercourse.
Mm-hmm.
Well, if sex hurts, then why do it? That just makes total sense. And I do see a lot of times women come in and their chief complaint is low libido. But really, when you get down to it, it's because sex is painful. So,
Mm-hmm. You don't
and that
desire
can,
something that causes pain. It's very
yeah, that's
uncomfortable.
totally normal. And
Mm-hmm.
they're worried about what's wrong with them, and I understand that, because our society, we don't talk about sex enough that women feel comfortable talking about it, so they hold it in and feel like they're broken, and they're not. Like there are things that happen as you age. Even without cancer, you can get vaginal dryness that causes painful sex. And one thing I notice is that usually is a symptom that shows up a couple years after your periods stop. So women don't know that that's related to the menopause, whereas they know that hot flashes are related to menopause because their periods are going haywire. They have hot flashes. We talk about hot flashes. But then they think, what's wrong with me? Or their partner says, why aren't you lubricated? Do you not love me anymore? Are you cheating? And no, it's normal. That's what happens. But there are plenty of things that you can use safely to help restore vaginal elasticity and vaginal moisture.
Mm-hmm.
So if that's part of the libido, then, we'll concentrate on that. And then what I'll usually do is go through a list of things that I recommend that are not medicine. And then I'll go through the risks, benefits, side effects of the medicines, and they can pick and choose how they would like to proceed.
I'm really curious since you brought up sex and cancer and how cancer can impact
Mhm.
a woman's body. So,
Yes.
I have a lot of people who come to me about this, and I'm curious if you can explain kind of the science behind why cancer can impact someone's sex life.
Well, for a variety of reasons. And one, it depends on the type of cancer. So some cancers impact a woman's sex life 20 times worse or 100 times worse than other ones. So
Mhm.
specifically breast cancer. And I see so many women with breast cancer in my practice, because breast cancer, basically, you lose your breast. Not always. You might have a lumpectomy, but either your breast, you might have scarring. So, breasts are a sex organ. If you have a mastectomy, they remove a breast or both breasts, and then you lose. A lot of times you'll have no nipple, there'll be no sensation.
Mhm.
And most surgeons don't mention that to women. And so they have no idea that there's going to be that loss of that sensation of, like nipple sensation. And for a lot of women, that's a very important part of who they are sexually. Women who have breast cancer also can be at higher risk for ovarian cancer. And so many of them will have their uterus and their ovaries removed. And so I see a lot of feelings of what is left of me that's woman, right? They took my breasts, they took my ovaries, they took my uterus. And what I say to that is you still have a clitoris, and that is an incredibly important sex organ, and you still have a vagina. So you can still have a fantastic, sex life, and you don't have to say, oh, well, it's all over because I had cancer. There's still plenty that you can do. The other cancers that I see this in are things like cervical cancer, vaginal cancer, colon, bladder, anything that affects the pelvis in general. If you have radiation to the pelvis, it can scar the vagina. And the worst thing I ever heard a patient tell me, and she had cervical cancer, and so they were doing radiation. She went in for her radiation treatment, and the physician was a guy, and he came in and said, oh, by the way, well, this is how she heard it. So I'm hearing her side of the story, but it was appalling to me. He said, oh, by the way, your vagina is going to close up. Here's a dilator. And that's what she heard. And I was like, my jaw, because it can. So that can happen. And so I help women use dilators to maintain vaginal patency. But that's how she heard it. And who knows if that's exactly how he said it. But if that's a horrible thing to just drop that ball and say, oh, by the way, your sex life is going to be ruined. So if people are listening and they have cervical cancer or vaginal cancer, or had pelvic radiation, that is not the case. You can use dilators. You can still use your vagina.
Well, and I do want to point out too, some of this is related to the cancer, but some of it's also related to the treatment, correct? That
correct.
It's some of the cancer treatment that can be very drying to the vagina, and that's part of why some women are having some of that pain. The radiation treatments really impact the whole body, correct? And so things change. Tell me a little more. I don't want to be the explainer. You're the doctor.
Yeah. No. So, well, it depends where you have the radiation. So radiation now is, it's gotten much better over the years in pinpointing the area that needs to be pinpointed, because you have a lot of side effects. Like if you have pelvic irradiation, your bowels are in there. You can have all sorts of bowel problems. So definitely since I started doing this, they're much better at focusing the radiation on the parts that need it. But yeah, radiation, it's like having a burn almost, and it makes you feel bad, and your skin might be burned, especially in breast radiation, it looks burned. And cancer just in general wears you out. You might be fatigued. You might be nauseated from treatment or something like that. But, it's hard to maintain a sex life. And the good news is that more and more people are living from when they have cancer. And so I have seen in the cancer community, which I think is fantastic, a move towards focusing on sexuality and quality of life. And I think that's really, really important. It's not only about let's get rid of the cancer and then you figure out the rest of your life. It's let's get rid of the cancer, and now we're going to help you have an excellent quality of life. And I think that's really important.
Yeah, I agree. Because what we were talking about earlier, how people label themselves and identify sexually. If you're in a context where people really aren't covering it, then people are left to do it on their own. And one of the most common things that female do is find a way to I call it imploding, but they take it personally. It's not one thing you said earlier is they think there's something wrong with me, and then I must be broken in some way. And that's how they kind of implode. And when you have a system, or at least a context where people are encouraging quality of life and quality of sex, then suddenly you can believe, no, maybe I can be a sexual person. It's changed, but it doesn't mean it can't be good. But I was thinking of that loss of identity. This is a grieving process that people go through, that they're not aware of how do you process that, and so that's the piece that's a part of it as well. In addition to just can't, I know, well, I don't want to say just can't. I hate the word just, because whenever I say that, it's let's just push cancer aside. It's not like that.
I know what you're trying to say.
I know. I overthink everything. It's my style. But so in addition to cancer, painful sex impacts a lot of people. So I'm curious, what are the other types of painful sex that you work with, and different ways they come from for your clients?
Yeah. So I see a lot of women with endometriosis. And that's another horrible condition. It takes on average visit with 7 providers to actually make the right diagnosis. And endometriosis is where you can have endometrial lining, which is the lining that you shed each month inside the uterus, can implant in the pelvis on ovaries, on bowel, on bladder, and it causes inflammation and terrible pain. Typically, people will present with really bad menstrual cramps that, they miss school or work, or they're so nauseated they're puking because the pain is so bad. And endo is awful. And it many times, not always, but many times it's part of a whole constellation of pain issues. So women with endometriosis are more likely to have bladder pain. They're more likely to have irritable bowel syndrome. They're more likely to have things like migraines and other pain syndromes, and also vulvodynia, which is pain of the vulva. Without like a lesion, there's no blister, there's no lesions, just the vulva hurts. And they're more likely to have pelvic floor muscle spasm as a response to pain, which leads to more pain. And so I think it's important that for somebody who has pelvic pain to really see a pelvic pain specialist, because it's so much more complicated than, oh, here, take a birth control pill. And there's so many sort of confounding factors that you want to make sure that all of those issues are addressed, because if you only focus on the endometriosis and not on the bladder pain, then the pain won't get completely better. So I do see a lot of endo, and I work really closely with the Pelvic Pain Center at SLU, St. Louis University, where they have excellent endometriosis surgeons and urogynecologists who are pelvic pain specialists. And then I handle the painful sex part. So it's sort of a multidisciplinary team because pain is so complicated. And so I think we have a good setup here in St. Louis.
No, I agree. And actually, so as a sex therapist, I started out learning about painful sex as a psychological disorder, which it's interesting because it was treated sort of like that in the beginning when people had painful sex. They were like, this is in your head, so you need to go see a therapist. And the hard thing about pain, just for any listeners, is that it's kind of a mix. Pain is real. When you feel pain, it's real. It is a real experience in your body. So it's physiological, but it does create psychological experiences as well. Because, of course, the anticipation of pain, the worry about pain, how is this going to impact in my sex? And so what I found in my practice is I really need to collaborate with other professionals like you, actually, Dr. Becky, where you're like, okay, you need to be with a medical professional. You need to have a physical therapist. We need to see the bigger, broader issue, because as you said, 7 doctors. I'm curious. Now I have a real question about that. Why does it take 7 doctors typically to diagnose?
Well, I think that, because a woman might come in with menstrual cramps, so we give her a birth control pill, but she still has pain. And the thing is that, maybe if she has endo, eventually someone will do a laparoscopy. That's the only way you can diagnose endometriosis, is with a surgery called laparoscopy, where you look inside the abdomen for the little endometriotic implants, the little lesions. Okay. And so, somebody comes in, they have pelvic pain, and their provider will, screen for STDs, it's negative, do a pelvic ultrasound, it's negative. And so we're so programmed to say, oh, look, everything's normal, so you're fine. So it must be, at least
based on those tests, right? But you didn't do the other test you needed.
Right, you didn't do the laparoscopy. And I think there's something to be said about that. You can't just take everybody who has menstrual cramps and go do surgery, because surgery has risks to it.
That makes sense.
But I think that you have to sort of be on the lookout as the provider when someone has really bad menstrual cramps, if they're not getting better, to think endo and to either go to do a laparoscopy or to refer them to somebody who's a specialist or somebody. Because if you go, I'm sort of biased in that I really believe if you think you have endo, or if I think a patient has endo, they should see an endometriosis surgeon, because those surgeons, they're MIG surgeons, which is minimally invasive gynecology. So they have extra training to get every last bit of endometriosis out. And so we're lucky here. We have 2 of them at SLU. But I think it just takes time, because there are really no physical findings. Women come in and just say, I have pelvic pain. And so with endo, they might start with menstrual cramps really bad. And then over time, it gets bad that they have pain all the time. And all the imaging you do shows nothing. So then they get this diagnosis, oh, it's in your head.
Mm-hmm.
One thing I wanted to say also about like what you do is that if you have chronic pain and you didn't have anxiety and depression before, now you're going to have anxiety and
Absolutely.
depression.
Like it goes together.
They do. And the thing with anxiety and depression is they turn up the amplifier on pain. They make your
Mm.
brain hear it so much worse. So that's part of the treatment of pelvic pain is to get the anxiety and depression under control so you can lower the volume on how loudly your brain hears pain.
Well, now you just triggered kind of something interesting.
Hmm.
I'm recently working with different kinds of clients who are struggling with, I'm not exactly sure what it's called, but it's where after pregnancy, their belly struggles to kind of heal and
Hmm.
come together. And so they feel kind of loose and it feels almost foreign, for example.
Hmm.
And I was thinking back to the cancer stuff where, like, if somebody loses their breast or if they lose parts of their femininity, it's like, you almost feel like there's this foreign thing going on in your body. And then there's the
Hmm.
anxiety and depression around it because it's like, wait, this isn't who I am. I don't know how to connect to this. And to your point, also it amplifies the way you feel. So like a big part of my job has been with clients who come with any of these different distressing factors is how do I help them shift that distress so that they're
Yeah.
dealing with pain when it's happening. Like actually a lot of it's mindfulness and teaching people to kind of
Yes.
like re-experience their their sexuality in new ways. Like for pain
Hmm.
during intercourse, one of the things I need to do is help people reassociate positive feelings with sex because they've had so many negative feelings. The way I kind of describe it is it's almost like you've traumatized the vagina to the point that it's
Yeah.
like, fuck off, I'm not having sex with you anymore.
Sorry, we're done. Drop the mic.
Exactly. And so
We're
it's
out.
exactly, we drop the mic, we're out of this because like, why would you do that? Why?
Yeah.
And so, yeah, it becomes this really complex process of, no, I'm physiologically struggling. I don't know what it is if it takes you 7 doctors to figure it out. And then there's all this
Yeah.
anxiety and depression around, will this ever be solved? Maybe you finally get the diagnosis, but oftentimes by the time people are coming to us,
Yep.
there's a lot of shit to deal
Yes.
with.
Yes. No, that's so true. And just because you get the diagnosis doesn't mean that you're not going to have pain anymore. There's
Yeah.
still, a road to travel to getting better. And some people with chronic pain will always have some element of pain. And the goal really is to get it to a really low level or a livable level.
Like
But
management.
but I do find it interesting, like your side of how you kind of need to redirect and make sex a positive thing as opposed to associating it with such negativity.
hmm So I want to ask you some more stuff because you also deal with PGAD, and I don't think I've
Yes.
done an episode talking about that. So
Yes.
can you explain PGAD? And let's
Absolutely.
go from there.
Yeah. So PGAD is persistent genital arousal disorder, although I think they're working on changing the name. So,
Okay.
we'll hear about that at some point.
hmm
And this is a condition where, and it happens in men and women. I only see women in my practice. I think it happens more in women than in men, where they have this constant feeling of arousal, like they need to orgasm, like they need to masturbate to get it to go away. And if they masturbate, it goes away temporarily and comes right back.
hmm
And it's awful. And it's kind of on the spectrum. When it gets really bad, it can be very painful. So it can be considered in some people sort of a pain syndrome as well. But if you think about this, how terrifying. And a lot of practitioners have never heard of it. When I was in medical school and residency, I never learned about it. It was really only recognized, I believe, in the early 2000s. And patients are mortified to bring this to a doctor. They think someone's going to tell them they're, I don't know, hypersexual, and that it's, a problem in their brain and it's bad. And, and why wouldn't they feel that way? If I didn't know what this was, I would be mortified to bring it. I wouldn't even know who to tell. And, but over the years, it's become more practitioners are learning about it. There's really not one overarching treatment. And we don't know exactly what causes it, but we do have some theories. But it can be anywhere from the brain to the spinal cord to, the clitoris itself that can cause that feeling. So there's not really okay, this is what you should do. There's not an algorithm. This is how you should treat patients, although they're all the experts are also working on publishing an algorithm. Maybe it's out now, but I don't know. I don't think so. And so it's a lot of trial and error, but it's just the most horrible condition. And I feel so bad for my patients who have it.
So is it like what I always think about it is like if this feeling of you need to pee but you're never able to quite satiate that feeling, where it's like it's just constantly
Yeah.
it's almost there but it's not quite. So it's not like a fun experience, and I think that's the
Right.
challenge when people describe it to others that aren't aware of it. So actually one time I was in like a room full of medical professionals, and we were allowed to send quiet questions up to the doctors. And so I put in a question about PGAD, and it's something along the lines of, though, what is the, like I have this persistent arousal and it just doesn't go away. And the doctor up there was like, well, that's a great condition. Good for you,
Oh, gosh.
And it was, well, because I was curious. I was like, do they know about it? And could they help with somebody who had this? And no, like that's actually a common response people get of like, well, hey, good for your partner. Or, it's just like, no, you don't understand. This is bad for me.
It's horrible. Yeah, no, that is definitely like for people who don't know, that's the response you get from a practitioner. So, hopefully as we learn more about it and more is published about it, that it'll, and more people are doing sexual medicine and treating sexual issues, the more people will know about it. There's a really excellent support group for PGAD. It's huge. There are hundreds of people all over the world. It's a Facebook support group. It's secret, closed, and private because, as you can imagine, it might get some creepers.
Yes.
So you have to. Like for my patients, I can get in touch with the person and she's the administrator, and then she'll add them. And which I'm sure she would for your patients too. But it's such a good Facebook support group because, as you can imagine, these people feel really alone, and the support group is really good at getting on there and being like, hey, I tried this and this worked, or I tried this, or you should go see, such and such. So I think that I have, quite a population of patients with PGAD in my practice because the support group knows where I am and that I take care of patients with PGAD. And so they come from all over.
What are some of the things what are the things that you use to treat people with PGAD? What are some of the options? I know you said it's trial and error, but I'm just curious what the range of options are.
Yeah. So first, my goal is to try and figure out why they have it. So I will definitely examine the clitoris. Are there adhesions? Is there something on the clitoris that is irritating it, or constant irritation that's, firing up the nerves so they constantly feel aroused? I'll check for pelvic floor muscle spasm. I will also usually get an MRI of the back because Tarloff cysts, which are little outpouchings of cerebrospinal fluid, and other spinal cord problems like herniated discs and annular tears can, as the nerves leave the spinal cord, can irritate the nerves and cause them to be continually firing. So I always battle with insurance companies because they'll always deny it first, which drives me crazy. But I'll do the battle.
Mm-hmm.
So if, let's say I do the whole exam and I don't find anything, a lot of times I will start with Chantix, which is not FDA approved for PGAD, but I have definitely seen it work. And the way that it works makes sense with PGAD. Sometimes I'll do a pudendal block, like if I decide that they have PGAD because of a pudendal issue. Like here's an example. Pudendal nerve is the nerve that supplies the clitoris and supplies the vulva and all that. So like an example of a patient I saw once was sitting on the back of the motorcycle of a partner, and the motorcycle took off and she fell off the back and landed right on her sacrum. Oh. And after that, she had PGAD. And so that's most likely due to some, pudendal bruising or something like that. So for some people, I'll do a pudendal block. Another reason that people seem to get PGAD is when you are changing their antidepressants. And we don't know exactly how or why, but we know that PGAD has something to do with dopamine in the brain. I can't tell you all the exact specifics, but when you switched people's antidepressants, sometimes they'll develop PGAD. And so that's a tough one because then, now you're going to add like Chantix or You can also do Ambien. These are both totally off-label uses. I usually go with the Chantix. But you can try those.
Huh, that's so interesting.
Yeah.
And so it's hard. It's hard because it's still being studied so much, and it's kind of relatively new that people are actually accepting that this is a diagnosis that needs to be treated. But it sounds like it's some version of a nerve condition or injury or kind of somewhere. And just to throw a little background in there, I actually watched this really cool TED Talk which talked about how orgasms actually come from the brain and the spine. The easiest way to get through them is through your genitals, but that's actually where they're located. And so when you talk about those spinal disc issues, I mean, naturally that makes sense because it's about how that nerve is wiring or misfiring essentially. And that's why it can be so complex in terms of how to treat, because also the nerves, we can't easily just say, oh, it's this nerve, this is the nerve, or that one, right? It can be a blend.
Yeah. Oh, I want to see that TED Talk.
I will have to. Oh, it was 10 interesting things you don't know about orgasm. And they talked about essentially that like they could give people dead people orgasms by touching a certain part of the spine. And I was thinking to myself, who's giving dead people orgasms? But okay, I mean, whatever you guys want to do.
I'll have to look that up.
Life choices. Yeah. That's all I have to say.
Yeah, exactly. Life choices.
Well, so, wow, this has been so interesting. So I kind of wanted to go into like maybe just a little bit about you, Dr. Becky. What got you into this field?
Yeah. So, so I knew that I wanted to do women's health even before I went to medical school. But I went to med school with an open mind. And in the end, I chose OBGYN. And for 6 years, I practiced just regular routine OBGYN in Jefferson City, Missouri, at a community hospital. And when I first got there, I can remember I had a couple patients ask me about low libido. And I had learned nothing about low libido during residency. And I didn't have an answer. And that really bothered me. And way back then, this was, not everything was on the internet. I got a card in the mail about a conference about women's sexuality. And I went to that conference and I learned so much. And I came back and I actually had an answer. I had some things that, I could offer to my patients with low libido. Ultimately, I went up to the University of Missouri in Columbia, and I can remember I was at a faculty meeting, and the urogynecologist was talking about how he really didn't have time in his practice to talk to women about sexual function. He wanted to operate. And so I raised my hand and I said, I'd be happy to see women who have sexual issues. And then after that, everyone referred me. And I thought, oh my gosh, I got to learn a whole bunch more than what I just learned at the one conference I did 6 years ago. So I found ISWISH, which is the International Society for the Study of Women's Sexual Health. It's a great resource. It's a great organization. And I went to a course and I've been going to their conferences, and I did a preceptorship with a physician in California where I shadowed him in his clinic to learn, how to do this and what he sees. And then I did the sexual counseling training. And I'm kind of a lifelong learner. I want to learn more. So I've just continued to practice and then stay on top of things and go to conferences, and I just love to learn. So, and I enjoy doing this because I feel it like it's so important. It is so important. And it's so, when you have a sexual issue, it's a multiplier effect. It spills out into your relationship and your happiness and your family. And, it's very important to address. And I'm comfortable talking about sex. It doesn't bother me in the least bit. And I know some people aren't. And so I want to make sure that I can help people in that way, and that women know that, they deserve a good sex life, and there's nothing wrong with them. We can work on this. There are changes that happen, but sex is important for women. And I think a lot of times we overlook that. We say, oh, for men, any man who gets started on an antidepressant, they're for sure going to be told about erectile dysfunction. But I find that women who get started on antidepressants, they have no idea that affected their ability to orgasm because nobody told them.
That's really interesting. So, it makes me think of the broader global influence around females and sexuality, which I know is like a big, broad topic, but, it speaks a lot to how we even teach women and men about sex and that it's okay to be sexual. That's why I talk a lot about permission and giving people identities, because I think there's a lot there's a lot to sexuality that is just giving yourself permission to be a sexual person. Like if that isn't allowed at the very beginning or somewhere in your life where you say, you know what, I'm going to be sexual and it's okay, then people really struggle. And, you know, it's funny you mentioned like you had to do extra training. I found that in my practice too, that like therapists don't, unless you become a sex therapist, you'll kind of lightly touch on it, but it's like, oh, it's sex. Let's refer you somewhere else. There is just a conservatism around sex and sexuality in the medical and the mental health field that is, I don't know, it's just odd. But I mean, not that odd given our cultural context. So like, it's like, sex. We look at it as kind of either pornographic or don't talk about it at all.
Exactly. It doesn't make sense, but that's the way it is.
Well, and when you have those two dynamics, I think what happens is people can't find a middle ground identity, right? So like I either get to be a whore or I'm a prude, right? It's like we got to find somewhere in the middle where it's like, no, you know what? I can be an educated woman and like sex. I can be an educated man and be a sexual person. I can be an accountant who likes sex.
That's right.
Well, so what are some of the, I was just like wondering if you have any, weird stories or unique stories, or like what's a common thing that a woman will say to you when you first meet her?
So I have noticed it kind of depends on the woman. So some women are completely open, talking about their sexuality, completely open, and other women can't say the word vagina out loud. So, and so, you know, I feel like a lot of what I do is create a space that's non-judgmental. I'll say the word vagina, it's just a body part. And, you know, like I do try very hard to just make it easy for those people who have trouble saying the word out loud.
Yeah, I've definitely noticed that.
I was going to say the one thing that I've noticed in the sexual counseling realm, and you may see this way more than I see this, but, you know, I have noticed that something that stuck out to me was that women stay in relationships for a zillion reasons, even when it's not a great relationship, you know? And women have sex for a zillion reasons. It's not always because they have desire. They might, you know, want something, or, you know, there's a zillion reasons women have sex. So I guess those are two things that I never had thought about in the past. But there they are.
Yeah. Yeah. The interesting ones for me are when it's for a chore. It's like, you know what? I'm going to have sex with you to get those curtains put up, man.
Yep. It's the barter system, you know.
There's bartering. There is sexual bartering going on.
Yep.
And there's kind of these expectations around sex that are making people not enjoy it. Like that, you know, this sort of sense of like, I need to do this or I have to do this is just the biggest desire killer.
Oh, absolutely. Yeah. So like duty sex, right? Where they just feel like they have to do it. So I see that a lot in my patients with low libido. So they feel like they have to have sex. They don't really want to. They do. It's not great sex. They don't get their needs taken care of. So it's not a great, not a great time. So the next time when sex is presented to them, they think back and be like, well, that wasn't so good. So I don't really want to do it. But they do it again and it's still bad. And it's just this like vicious cycle and downward spiral. And so, you know, I talk a lot about, you know, getting your own needs met. I do think there are some women who feel like sex is all about the man. And once he's done, it's over. And, you know, that's not the case. You know, in order to want to have sex, you have to have your needs met. So sex is selfish and selfless.
Absolutely. No, I've totally seen that in my practice too, where people just, I don't know, like, I wish there was another medium that really showed people what good sex looks like other than porn, because I know that that's like, it's the hidden thing under there that people see. And I'm not opposed to porn. I don't really care about it, right? It's just like, okay, it's what people use to get off alone. But what I do struggle with it is that people don't have this other visual of what good sex could be, what it could look like. There aren't a lot of great examples. Like even in shows where it's kind of romantic, people are having very quick sex or they fade off into the background depending on the rating system. And you're just not seeing what real sex looks like. And so I find so much of my time in session is teaching people, well, here's how some people do it, and here's how other people do it. And actually, here's how it can be very casual for some people, and here's how it can be planned for others. And that is not that odd to do those things, but because there's all these preconceived notions about what is good sex or what it should be, it's got to be spontaneous and magical all the time, then they feel like they're doing it wrong, and then they just keep that downward spiral.
Yeah. So I think that's really interesting. And I feel like I see a lot of women come in and think they always have to orgasm vaginally when we know that many women can't. And they feel like it should always happen when the man happens because that's what happens in the movies. So
exactly. They do it all the time like that.
And that's really not how it works the majority of the time. So actually, I wanted to ask you, do you have any good resources for your clients that, so they can see what real sex looks like? Are there handouts, or do you just talk about it? Because I would love to have something like that to offer my patients.
Absolutely. Well, so I'll tell you a few things. I actually have been putting together a YouTube channel now for a few years where I just put out tidbits of like, here's an example of how people deal with a gray zone where you're kind of trying to figure out, I'm kind of interested, I'm kind of not interested, I'm not there yet, but here's what we could do to get there. Like that's a gray zone where it's like sex is kind of on the table, but nobody's feeling like they're at a 10, right? So like I put out little videos like that where I'm teaching people just little skills and strategies. But even beyond that, there is this old show I used to watch, and this is part of what got me into my field, is Real Sex from HBO. When I was like, I'm embarrassed to say it, but I was like 12 and 13 watching this show for adults and like HBO. It's when I learned, right? But like it was real people talking about what they do sexually, what turns them on, what's interesting. And some of them were weird, some of them were sexy. And I was like, I didn't know that was a thing. But I felt like that was a cool representation. They'd interview people on the street. So there's that.
Oh, wow.
I feel like actually the Playboy channel has been doing better because now that porn is free and easily accessible, Playboy has had to shift its approach. And so actually Playboy is making more couples-related like sexual programming that couples are finding fun and interesting because they had to find a way to do something special. It's not special to be naked anymore, know?
Right.
And
it's so easy to see that.
Exactly. And then also, I just get people on a sexual journey. Like there's TED Talks about sex. There's information like the Guide to Getting It On, which is a great, I call it the Sex Bible, but it's just chapters to get people learning. And really a big part of what I do is immerse people in sexual education. So they're starting to learn. But then of course, absolutely in my practice, I'm teaching people, I'm trying to coordinate it so that it works for their life. And I'm also trying to teach them that they can have their own personality and even flirtation styles. Like I taught this one couple that they overthink everything. I was like, well, you can use overthinking as a flirtation style, right? And they were like, no, you can. And, and so, and I don't care how it happens. I just want people to find their version of good sexuality. Like that's my important goal. So thank you for asking. Well,
that's awesome.
I'm curious, because we're kind of towards the end of the episode, what are just some final pieces of information you want people to know about you, what you do, all of that good stuff?
Yeah. So I in case anybody needs me, I'm at St. Luke's in Chesterfield. I'm at Evora Women's Health. We see all comers, sexual problems, menopause. Those are our two main specialties. So you can find me at evorawomen.com. Our phone number is 314-934-0551. And we also do a free 15-minute visit if someone just wants to meet me, because this is a very embarrassing topic. So if they just want to meet me for 15 minutes and see if we're the right fit, they can do that. And they can schedule that by calling or going to our website. And I have Facebook and Instagram, which is at Evora Women's Health or at Becky Lynn MD. And I love social media too. And I feel like it's a great tool to educate people. Like we're talking about, you don't get enough education about what's normal. So I do a lot of that on social media. And I also have a YouTube channel. So that's how they can find me.
Excellent. And we'll have all the links in the blog. So thank you again, Dr. Becky Lynn, for joining me. And you all have been listening to the About Sex podcast. That's www.aboutsexpodcast.com. And you can also find me as a therapist at www.therapistinstlouis.com. Thank you all for joining me, and stay kinky, St. Louis.